Hello and welcome to Clinical Skills R Us. I'm Stuart Metcalfe, a consultant podiatric surgeon, and we are going to be talking in this presentation about a condition called Sever's disease, a common cause of heel pain. The presentation is brought to you by Clinical Skills R Us, a clinical education company that deliver practical clinical education and training for people in healthcare, particularly relating to foot, ankle and lower limb type pathologies. So let's begin. So Sever's disease is a common condition. It was first described, or it's credited to a gentleman by the names of James Warren Sever, and he characterized this in a publication in 1912. And it's certainly a very common cause of heel pain. And what we'll do is we'll look at some of the anatomy involved first of all, and I'll talk you through the presentation of the condition and more importantly the treatment approaches that I use successfully in a large number of cases that I see every year. Okay, so I finally managed to turn on my laser pointer, which hopefully will help us as we go through. So apologies if it sends you dizzy at times. So Sever disease then, more correctly I suppose, is known as calcaneal, referring to the heel, apophysitis, and it's really an inflammation of the growth plate in the heel of a growing bone. And of course it isn't seen in adults where the growth plate is closed, because obviously if there's no growth plate, the growth plate can't be present, and so it's a condition that we really only consider in children, typically between the age of 8 and 14 years. And it's really characterized by pain in the heel, particularly at the sides of the heel, as you'll see here, very common in active children. So let's have a look at some anatomy. Well, this is a lateral x-ray. This is the talus here that we can see. There is the heel bone looking laterally. And the subtalar joint, this is the posterior facet of the subtalar joint. And this is the apophysis here. Oops, apologise for that loud beep. I was hoping to get rid of that. But you can see this is the back of the heel bone, and the growth plate joins that back of the heel bone to the main body of the bone here. And this is where the problems and symptoms arise in Sever's disease or calcaneal apophysitis. So an apophysis then is a growth plate that's under traction, as opposed to a normal growth plate that we see, which we refer to as an epiphysis. So we're going to just look at the mechanics of Sever's. This is an illustration I've taken from my e-learning and talk course module on essential biomechanics. What I'm showing here is that the ground reaction forces of the foot act up here, and we've got the pivot of the ankle joint here providing sagittal plane movement. There's the apophysis on the posterior aspect of the heel, just marked roughly in yellow dotted lines. And we've got then the pull of the Achilles tendon via the gastrocnemius soleus muscle group, where the Achilles tendon comes around and inserts to the posterior aspect. So you can see that there is a traction developing here across the apophysis as a result of the pull of the gastrocnemius soleus muscle group via the Achilles. And it can be aggravated by ground reaction force during the propulsive phase of gait, because these two factors are acting kind of in opposite directions. So the bottom line is, we don't need to make this too complicated, is that this area here, this apophysis, is subject to quite a lot of mechanical stress and strain. And I think you can see easily that if there's more pull because of, say, tightness or overactivity of gastrocnemius, there'll be an increased stress loading across the apophysis. If the child increases mechanical load through increasing activity or because of obesity, all of these factors will increase the mechanical stress on the apophysis. So that's the basic mechanics, and understanding that in very simple terms is going to help us work out how to treat this condition. Now, just have a look at the characterized symptoms of this condition. So the number one thing is we've already said that this is a condition we see in children, particularly between the age of 8 and 12 years. And the pain is very much located in this region. This is the outer aspect of the heel. So you squeeze on the side of the heel bone towards the back, and often you will elicit an ouch, or often displayed in several other ways in kids. And what is important in terms of differential diagnosis is the pain is not located here. This is the plantar calcaneal tubercle here, and nor is it radiating along the medial arch, which is more characteristic of plantar fasciitis. What can be slightly confusing in Severs is children often complain of insertional Achilles tendon pain, and so that is quite commonly seen, which is why I've put this in the pink arrow. We don't generally see in pure Severs pain of the Achilles tendinopathy, which is more in the mid-substance of the Achilles tendon. So it's quite straightforward in terms of clinical diagnosis. We've got characteristic pain in relation to activity. We've got a child of age normally between 8 and 12, and we've got pain in this region of the heel bone, not usually in this region of the heel bone, sometimes also here, but not generally in the Achilles tendon. These are guides only, of course, and it is possible for children to present with coexisting pathology. And indeed, there are some rare conditions that can mimic Severs, but they are extremely unusual. Incidence-wise, well, it's seen allegedly in about 3.7 in 1,000 children, but probably the incidence is much higher. As I've said, boys between 8 and 10. In girls, typically a little bit older than this, normally 10 to 12 years of age, and often characterized, if you speak to the mum or dad, in children where there's been a growth spurt. And this is probably because what's happened is the muscle tendon unit has become tighter as the child has grown more quickly than the soft tissues have been able to accommodate. And children involved in sports, particularly those that involve running and jumping, impact activities in Severs have a very strong correlation. So sadly, we live in a world of ever increasing body mass index, obesity, and certainly anything that adds to the mechanical load of this condition is likely to increase the risk of Severs, and childhood obesity is something that is becoming ever more prevalent, unfortunately. As with all conditions, we need to consider a differential diagnosis in terms of cause of heel pain. I've already mentioned a couple. So insertional pain, that's where the Achilles inserts into the back of the heel bone, might be associated with things like Haglund's, posterior calcaneal exostoses, that's the posh phrase for lumps of bone on the heel. Bursitis is another cause of insertional pain here. Plantar fasciitis, that's easily distinguished, although it can coexist. And primary Achilles tendinopathy, and typically this pain is higher up in the Achilles tendon, usually somewhere between the insertion and the origin at the myotendinous junction. That just means where the muscle and tendon begin to form. Pretty easy condition then to diagnose clinically. X-rays, well, no, we mustn't be sending patients that we think have got Severs for X-rays. You'll get your knuckles wrapped by the radiologist for doing this. Historically, we do this all the time, but then historically we do lots of things that we don't do nowadays. The X-rays have a very, very low sensitivity and a very low specificity. In other words, they're pretty useless for diagnosing this condition. We would, however, consider organising an X-ray if our primary diagnosis of Severs wasn't responding as we had expected, and we specifically wanted to exclude a differential diagnosis, for example, a primary bone tumour or fracture. And so it's perfectly reasonable in those circumstances to consider an X-ray. So any of us used to treating children will know that they come with parents, and therefore we're treating the child and the parent. So the first stage of treatment for severs is really to help the child get over the level of pain. And this is a three-pronged attack. So rest, advice, and pain management. I suppose we could use the acronym RAP, but I'd forgotten to highlight the letters in red. Sorry about that, I'm just moving at my desk. So rest, so the first thing we want to do really is to look at the activity levels of the child, and we will have already done that as part of our clinical history. We can maybe invite the child and parent to look at modifying their activity to try and engage them in a form of partial rest. Orthotics to me play a major role in helping them mitigate the mechanical load on the apophysis, and I'll come on to that in the next slide or so. Advice, I said that we're treating the parents as well as the child, and really it's very important to reassure parents and the child. The prognosis is good. These conditions always respond to treatment, although it can take several weeks sometimes to get symptoms to a tolerable level. Footwear advice is important. So first of all, I advise children never to walk around in bare feet, to always use shoes that have got a good amount of heel support, i.e. to take the traction off the apophysis. And you might want to have a close look at their day-to-day school shoes and also their sports footwear. This is a really important part of any management program when it comes to foot and ankle pathology. Managing pain, I often advise physical therapy such as ice, particularly if a child's engaged in sports. They can ice for 20 minutes. There's more information about the management plan in the biomechanics module on my e-learning site. If the pain is quite severe, we can begin to look at providing a child with analgesics. If you don't feel comfortable with prescribing yourself, then have them go and speak to a pharmacist. Pharmacists very well qualified nowadays to be advising mums and dads, children on analgesic therapy, rather than having to send them off to their GP. That simply wastes GP time. Whoops, I'm trying to move to the next slide. So the role of orthotics in severs is, for me, quite important, part of my management plan. It provides a key element of this partial rest program in combination with footwear. So these two things always in my clinical practice go hand in hand. So back to orthotics. There are numerous types of over-the-counter devices. Here you've got the Vasili AOL type devices. You've got these kind of gel heel pads. For me, prescribing an over-the-counter orthotic is pretty much like wearing shoes that aren't fitted correctly, and they're not for me. I'm not saying that they shouldn't be used. That's for you to judge. But for me, if I'm providing an orthotic for a child or indeed an adult, then I want to make sure that it's properly fitted and it's doing the job that I need it to do through the correct prescription. Now, the thing about the orthotic, of course, is that your child that you're treating may well present with other biomechanical anomalies, such as flexible flat foot, with hyperpronation that might require some orthotic control in addition to management of the Sever's disease. So I use a 3D scanning system from Foot Health EU. This allows me to take a full 3D scan, and I can use this system to write a prescription. You'll see here's a child in an orthotic. That this child has Severs and also pes plano valgus, and the orthotic I've designed in such a way to provide anti-pronatory control through support along the medial arch. And a key point is, as I've raised the heel here, temporarily at least, to take the traction off the Achilles tendon and therefore reduce the tension or the mechanical pull across the apophysis while the child is walking. Now, obviously, as part of my management plan in the first instance, I'm primarily aiming treatment at reducing symptoms whilst trying to maintain the child's near normal activity. I usually try and mitigate their activity levels a little bit, but I try to keep them engaged in sport if I can. And this is a judgment call depending on their level of symptoms. So the overall goal is to reduce mechanical load, and it's a matter of judgment how much you do, and that can be everything from complete rest to partial rest. I prescribe them a bespoke orthotic, and I tailor that prescription to the needs of the individual patient. If it's purely severs, then a little bit of support along the arch, a heel raise that's well fitted to lift them up, and you can also, if you want to, put a heel cushion in the prescription on the inside as well. Stage 2 treatment really is all about removing risk factors, and so once the symptoms are reduced, we might want to focus our attention to trying to address any soft tissue equinus deformity, which is typically present, and optimize function. So that's a good look at their overall lower limb, a general function, looking at things like hamstring tightness, gastrocnemius, cilius tightness. Is there any pes plano valgus hyperpronation present or not? These are key points. Also, if they are engaged in sport, as many of these kids are, we want to start talking to them about their warm-up and stretching. And typically, in my experience, 9 out of 10 children will look at you completely blank when it comes to these really important bits. Even though kids can get away without proper warm-up and without proper stretches in the early days, getting them into the mindset of understanding how important these things are will play a key role in their later life for injury prevention, because these things then become more of a habit. Trying to get a 35-year-old who's got a sports injury to change their ways is much more difficult than if you've got a child that's been brought up on doing stuff in the right way. So once the symptoms have subsided quite a bit, we're then aiming our treatment at removing risk factors and optimizing function. And this is all about reducing the risk of future injury, future problems. So I just clicked the wrong button then, so I was kind of wondering why we hadn't advanced to the next slide. Prognosis, I've said already, this is really good. It might take several weeks or sometimes months for pain to completely stop. If you ignore it, and many kids and parents do initially, typically the condition will get worse, and that just makes stuff more difficult to treat. When the pain is gone completely or significantly, so usually if there's a 70% reduction in pain and the VAS scores are maybe only 2 to 3 out of 10, I gradually get them back into their previous levels of activity with protection with the orthoses. Future growth spurts can precipitate further recurrences of the condition, but of course a well-informed parent and child then know just what to do, and they may not need to consult you straight away, or you might need to remodify their orthotics. If you've reduced the heel raise, you might need to reintroduce that temporarily. So I hope you found the presentation useful. It's been brought to you by Clinical Skills R Us. At the moment, you can access these courses through footconsultant.com/courses. I'm Stuart Metcalfe, a consultant podiatric surgeon. If you need to contact me, you can do so by my website for further information, or I'm very happy to help in providing information and advice on clinical cases. So I hope you enjoyed it, and have a great day.